There we go. Okay. Well, hello and welcome. Good afternoon to those of you on the East Coast, and good morning to those of you that will be joining from the Midwest and points beyond. We're glad to have you here today for, I think, a really good webinar session. For those of you who don't know me, I'm John Staley. I'll just briefly kind of go over a few logistical things, housekeeping items. I'm a associate professor in Gilling School of Global Public Health, Department of Environmental Sciences and Engineering, and I am Deputy Director of the North Carolina Occupational Safety and Health Education Research Center, which is a NIOSH-funded ERC, and co-lead of the Outreach Corps with Dr. Alice Ammerman for the Carolina Center for Healthy Work Design and Worker Wellbeing. So just to let you know, this presentation, the slides, the recording will all be available on both the Carolina Center and the North Carolina OSHRC websites, so both centers, and as well as an evaluation survey. I will put the links to the centers in the chat, and I would suggest bookmarking those for future reference, and also the evaluation survey at the end here. So please just take a moment to do that. It will only take you about 30-45 seconds. So, and it's really helpful in helping us do our tracking and figure out the direction for future webinars. It's important to note only those formerly registered for each seminar receives a follow-up email. So please make sure that you register if you didn't, if someone forwarded you the link. So if there are any NIOSH trainees joining us today, the evaluation survey is also required for your required attendance credit. Alrighty. So if you're not familiar, briefly, just the goal of the Carolina Center is to generate new knowledge, improve worker safety and health in not only the well-being of workers in North Carolina, but the southeastern region, the U.S. and the nation. And we have a special focus on essential workers and the impact of working conditions on health goals. And the goal of NC we provide high quality education and research training in occupational safety and health to promote worker safety and health. So we work together across both centers in that regard. If you need a certificate for continuing education or CM maintenance points within 2 weeks of this live seminar, please send an email to NC OSHRC's email address, and it's listed in a slide. Plus, it'll again be up on our website to request a certificate if it's needed. And I mentioned the goal of the center. So the Carolina Center is a center for excellence in total worker health, one of 10 funded in the United States by NIOSH, and the only one here in the Southeast region. A couple of research projects that we have ongoing is our rural and urban clinician well-being study. That's as well as our study looking at reducing falls and advancing protection in first responders, specifically firefighters. And we do fund pilot projects if you're not aware. And there's a few that are ongoing, whether it's opioid misuse, psychosocial safety for disadvantaged mothers, or job stress for in regards to construction workers. Also, you'll see all of our connection information, and whether it's a QR code, if you decide to scan, look at our centers, as well as all of our wonderful social media links. So feel free to take a look at that information as well. And you'll see this post-webinar evaluation code at the end pop back up. Again, please take a moment to fill that out when you are done. So with that said, I'm going to turn it over to Alice Ammerman, and she will introduce our speakers.
Hello, everybody. Really happy to be able to introduce these two speakers. I'm excited about this talk. We have Jeremy Bray. He is the Distinguished Professor of Economics at UNC Greensboro with 30 years of experience looking at economic evaluation of workplace interventions. He is a member of the Evaluation and Planning Core for the Carolina Center that you just heard about. And he serves as a consultant for all of our projects in terms of economic measures to be used. And we look to him for a lot of guidance. And then also Bruce Sherman. He has many degrees after his name and letters, one of which is MD. Then I also learned he's a fellow in occupational and environmental medicine. He's a workforce health and well-being consultant to employers, and he focuses on optimizing investments in equitable workforce health and well-being. He's an adjunct professor in public health education at UNCG, Greensboro, and he serves as medical director of the North Carolina Business Coalition on Health. So we're really looking forward to this talk. And if you have questions, put them in the chat, and John will be monitoring that, and we're hoping to have some time to discuss at the end as well. So I'm going to let Jeremy and Bruce take it away with their slides.
Thank you, Alice. Bruce is going to be driving our train for us. So while he's getting up, let me jump right in and just thank everybody for being here, and thank you, Alice and John and the Carolina Center for having us. Today we want to talk a little bit about the business case for total worker health, and in particular maybe a new way of thinking about the business case and how to establish it. And let me go on and just thank a few people. On to the next slide, Bruce. It takes a village. As always, I want to thank all our collaborators at the Carolina Center. Laura Linan, the principal investigator of the Carolina Center on my left, who she keeps the trains running there. My colleagues over at RTI on the evaluation core, Georgia Crunsis, Jules Payne. Colleagues at UNCG, Dan Bebo, Gracie Lee Weaver, some students of mine, Eli Unzel, Scarlett Rupert, and of course, Bruce. He's, co-presenting with me today, but a lot of my thinking on the business case for total worker health has been heavily influenced by him. So I'm really glad he's here to share that wisdom with you all. We can move on. So, and we can skip yet again, right? So let's start by just thinking about what we currently understand the business case to be. And this is a term that NIOSH uses quite a bit in trying to build a broader evidence base for total worker health, which of course is trying to bring together concepts of worker wellness and worker well-being with more traditional concepts of occupational safety and health. And NIOSH thinks about the business case as really being an economic evaluation to help compare costs and benefits of different interventions, but in particular trying to establish for businesses that total worker health interventions actually have a positive return and can positively impact the business's bottom line. And so this concept then is at the core of successful business. I also want to touch on a concept from HERO, which is very tightly linked to that idea, but HERO specifically uses the term return on investment. And I think that's important to note that really has dominated the evidence to date. And we can move on to the next slide, Bruce. So now that we know what the business case is, let's step back and ask, well, why are we as researchers, why is NIOSH interested in the business case? I mean, it seems obvious that a workplace would be interested, and the employer would want to know that a program they have implemented is having a positive impact on their business. But why are other entities, why is it such a big issue in the research field? Well, one, we think that this is, as researchers, we think this is absolutely critical to advancing total worker health programs. And so we think there is this desire by employers to understand this. But NIOSH also thinks that is then really critical to advancing worker well-being more generally. And research has shown that we do see this positive effect, and so that then leads us to think that ultimately having healthy employees can be beneficial to employers, and that is ultimately where we're trying to go. On Bruce. And I am moving through these pretty quickly because what we want to get to is not what the status quo is, but what our new thinking is. And do feel free to throw questions into the chat as you have them. Alice or John will help me keep track of that. So what do we usually do to build the business case? Well, there are several standard approaches. Cost analysis being one of them, and these are broad studies that try to establish that healthy employees are cost beneficial to employers, or put another way, that unhealthy employees impose a burden on employers. And so there you get cost of illness studies, studies of program implementation costs to show that programs to improve the health of employees really are not that expensive. Then you also have, broadly speaking, benefit cost studies. There are several types of these. Again, the most dominant being return on investment, or ROI. But you could just look at net benefit, which is the total amount of money saved, or a benefit cost ratio, which is very similar to return on investment, but not quite the same. And more recently, we're seeing the concept of value on investment, or VOI, being brought forward to expand the concepts of the return beyond traditional healthcare costs or productivity. And that concept of VOI is now sort of being used in the context of cost effectiveness, where we're not thinking about the benefits of total worker health necessarily just in dollar terms, but in other strategic goals that the workplace might have. And so then it becomes a question of how do we most cost efficiently achieve those goals. All right, Bruce.
So the question is are the processes that we have in place working now? And as you can see, our sense is not really. We are committed, or the industry seems to be committed to ROI, return on investment. The vendors perpetuate that from wellness, well-being, and even health benefits vendor perspective. And employers, I think, have been loath to transition from ROI to broader measures of VOI, as Jeremy has described, for a number of reasons. It's more complicated to quantify VOI. Vendors generally only have the data related to their programs, so it's hard for them, and medical claims data, so it's hard for them to broaden their quantification of value. And as a result, even though VOIs came on the scene from my vantage point in probably 2012, 2013, I would say fewer than 5% of employers are embracing or have embraced VOI as an accepted part of their business practices. And we can talk a little bit about why that is the case. And probably the biggest aspect of this is the fact that there are cost and performance or work output silos within organizations. Cost is managed by human resources, who manages all of the components of personnel. And traditionally within organizations, they've been viewed as cost centers. On the other hand, business operations is where the profit is generated, and that part of the organization has its own language, its own metrics relative to human resources, and those are typically not transparent to human resources personnel. So while there is a sense of being able to generate value for most employers, as long as the value of work output is greater than the cost of human resources, employers are largely content to stay focused on their operational silos, and consequently, human resources is focused more so on ROI, because they're using healthcare costs as a measure of return on investment. But the good news is that we are seeing changes in the marketplace, and from my perspective, we're seeing what is effectively a continuum transitioning from program-specific offerings to looking more broadly at health and productivity. This in the late 90s, organizations like the Institute for Health and Productivity Management and Integrated Benefits Institute popularized health and productivity metrics. But one of the problems there is that presenteeism really isn't a measure that that resonates for most employers. But I think as healthcare costs become a more significant portion of employer costs, and also with growing technological capabilities, I think we're seeing more and more organizations start to look more meaningfully at a more holistic view and of investments in employee or workforce health, and seeing that as part of a broader business imperative, which is the organizational culture of health. So as we talk about a new framework and transitioning to thinking about a more comprehensive and more meaningful business case, is that there's an important public health objective here, and that is have employers as private entities think about more seriously about investing in the health and well-being of the U.S. workforce, so as to improve health and well-being and potentially create additional business value. And the business case expands the value proposition from a narrowly defined ROI, typically expressed in terms of changes in healthcare costs, to a more comprehensive and meaningful perspective from the employer standpoint that is a manifestation of business value. And for employers that can do that and can quantify that business value, what that does is it provides a more compelling evidence to invest more assertively and substantially in workforce health and well-being. So what do we do now? Well, let's just take a little bit of a pause and think about where we've been. And that is a good analogy is essentially Rudyard Kipling's Elephant, the 10 Blind Men and the Elephant. And you can see here that we've looked at the workforce health and well-being from a series of different perspectives, and each stakeholder has a different sense of what's happening or what their experience has been when in contact with the elephant that is workforce health and well-being. And if we can transition over to a more holistic and comprehensive approach, we will have I think, a more meaningful framework or context into which to put our analyses and discussions of workforce health and well-being and the associated business impacts.
And so as we think about that conceptual model, that framework, we have several available to us. We don't have to start from whole cloth. And one that we've started with is the Harvard conceptual model for research on work safety, health, and well-being. And this model borrows or was influenced by the social ecological model itself, which then thinks about the different levels, the social, political, and economic environment within which the businesses operate, and within that, employment and labor patterns. And then you look at the enterprise and the worker, and the Harvard model really focuses in on those two levels. And while business case concepts certainly can be thought of as being in here, and the enterprise outcomes and some of the elements of job design or workplace policies, and certainly in some of the safety, health, and well-being outcomes, the business case itself, this concept of business value is not explicit in the model. And so we wanted to look for ways to incorporate that. Next slide, Bruce. And so that brought us to thoughts of, well, how do we do that, and how do we incorporate concepts of economic evaluation? And what an economic evaluation does is it explicitly compares costs to consequences, or sort of more broadly, the value of inputs, the value of resources committed to something, compared to the value of the benefits that something engenders. And in this figure, we're talking about a healthcare program, but we can also think about that as a workplace health and wellness program, workplace occupational safety and health. So what are the resources being committed to improving worker health and safety? And then what do we think are the benefits of doing that? And when you say value, when I say value, you may think we mean in explicitly monetary terms, but actually we don't. We need broader concepts of value to think about in intrinsic concepts of value, of being best place to work kinds of ideas. And we need to expand out of those boxes that the Harvard model stayed within, and move to different levels within that model. Go ahead, Bruce. Thank you. And then, of course, we also then want to think about, well, how do we create this workplace culture of health? What are the inputs that we need to think about for changing workplace culture, and what are those consequences, those potential benefits? And so we've got this conceptual framework, thanks to Bruce and his co-author, for us to draw upon to really expand our concept of what those inputs and senses of value might be. Go ahead, Bruce. And so now I'm going to show you very much a work in progress. I think Bruce and I have been hand-wringing over this model for quite a while now, much longer than I ever thought we would. And while I think conceptually we know what we want it to say, I don't think this picture is saying it yet. And so I certainly would value feedback and thoughts. But as you can see, we have sort of this sense of inputs and benefits. So what is the value of the resources committed to total worker health, or a culture of health, maybe is a better way to say it? And what do we think are the value then of the benefits? And again, we need to think more broadly than just monetary terms. And then somehow we have to compare the value of those resources committed to the value of the benefits in a way that speaks to the stakeholder and creates a stakeholder value proposition. And that's where this figure really falls short, is currently drawn, because it doesn't cut across the levels. It looks like it's nested within this micro level, which, if we borrow the Harvard terminology, would be the employee, or maybe the employer. And while certainly those are incredibly relevant and probably the most proximal perspectives for us to think about, we also have industry and union groups that we need to think about, and sort of expand beyond the individual employee or the individual employer, and think more broadly. We have within employers, we have those different stakeholders that Bruce was talking about the organizational and the HR. And then, of course, ultimately, we also have, NIOSH and public policy and the groups, the heroes, so the groups that are trying to promote this culture of health and trying to convince workplaces that this is something worth investing in some way. And so we need to be able to speak to those levels of the model as well. And so that's what we're striving towards, is coming up with a conceptual framework that encompasses, again, this broader sense of a value proposition, as well as a broader sense of the stakeholders, recognizing that no one study, no one research project necessarily can speak to all elements, but we think that a broader research agenda needs to encompass all elements and embody them in some way. And now Bruce is going to tell us a little bit about some of the challenges or operationalizations of ways that maybe we can do that.
Thanks, Jeremy. One of the in my experience, one of the things that I hear from employers and individuals who are involved with health and well-being program implementation is the fact that, well, employers don't really have a set of business associated measures or metrics that can be used to incorporate into establishing this broader assessment or analysis of value. And I would respectfully disagree. Business operations have generally a whole host of key performance indicators that they use to assess the ongoing success of the business. And I think one of the most important things that one can do is when approaching an individual employer is understand what do they feel are measures or metrics that are of the greatest importance to them. Because the more that we can quantify value in terms, as Jeremy mentioned, in terms that resonate with employers, the more meaningful those will be from a business standpoint for employers. And I'll use presenteeism as an example of a great construct that just hasn't caught or hasn't gained traction with employers.
And Bruce, we've got a question in the Q&A asking about public health, community health metrics, and do we think some of those might be good to integrate into the existing into sort of this framework?
I would think absolutely. My sense is that it would be critical to understand which of those metrics would be of value, at least from the employer perspective. But again, dealing with other stakeholder groups, I think the broader the model, and Jeremy, this goes back to the prior slide, the broader the model, the more relevance and consequence use of those broader set of measures could well generate. So I hope that addresses the question. Jeremy, if you've got other thoughts on that, please feel free to share.
Well, I think you're absolutely right, and that was a very perceptive question, I think, and I guess we think about the broader evidence base demonstrating that some of the employer-employee metrics and concepts that we're thinking about actually have a tie to public health metrics, broader community health metrics, I think then speaks to that higher level in the model. And I mentioned NIOSH as being one of those higher levels, but NIOSH then has to go to Congress to get funding. And as somebody working in the Carolina Center and knowing that every penny is priceless, as it were, I think being able to establish that and show that it is having a public health return is absolutely critical. And so, yeah, I think that is very much something that needs to be a part of the value proposition.
Great.
Thank you, Bruce.
One thing I wanted to just highlight on this slide, just giving some illustrative examples as to how um, certain measures exist across all industries, while some may be specific to various types of industries. And I think the other point to make here, if you look at the left and the right two columns, one reflects individual business performance measures, while the other one reflects aggregate measures. The point to make here is that individuals don't typically work in isolation in companies, and they may work as part of a business unit. So it may be more relevant for some companies to target business units rather than looking at individual specific or individually attributable business performance measures. The bottom line is there are a lot of ways to look at results, and I want to give you a few examples of what those can look like. But before I do that, the other thing I wanted to share is the fact that many business relevant measures, especially from a quantitative value perspective, take time to be realized. And this, most notably from a benefit standpoint, includes healthcare costs, which may take a year or 2 or 3 to change following changes in health benefits. And from that perspective, it may be better to use early indicators as directional measures or directional indicators of what impact implemented programs are having, and use those results as directional changes that support favorable long-term outcomes. If the early indicators are favorable, then it's likely or more likely that the long-term outcomes will be favorable as well. So if one doesn't see favorable early indicator trends, then maybe time to take a step back and look at outcomes and look at the program and see where problems or barriers are to programs being more successful. So I wanted to give you a couple of examples. This one is I included intentionally because it is raw, unadjusted data, but it's certainly enough to get business leadership attention. And this was an analysis of employee healthcare costs at 5 different union facilities, all with the same health benefits design and contract, and correlating that to a business performance measure, which was waste production as a percentage of final stock value, because each of these plants was making something different, but they were all part of the same company. This is a way of essentially normalizing the comparison between the different facilities. And each one of these facilities had about 2,500 employees working at them. And what is intriguing is that if one could lower healthcare costs, let's say through strategic and thoughtful health management programming, there appears to be about a 0.5% reduction in waste production, which means that there is a greater ability of those locations to enhance performance or productivity by generating less product that is not viable. And when we did the math to look at this based on the overall dollar value of the annual production in each of these facilities, what we appreciated that was that, and this is not a cause and effect, but certainly an association, if this trend holds, if we could reduce, or if employee healthcare costs could be reduced by $1,000, that 0.5% reduction in waste production actually increases the value of business output by $2,000. So this is a very simple, not statistically rigorous way of demonstrating that we can enhance the business proposition for addressing employee healthcare costs or improving employee health because of the associated business value that is could be generated as a consequence. The other example I'll give you is work from Gallup that as an organization has been very involved with studying employee engagement. And the number one reason for employee engagement, and tying this back to health and well-being, is my employer cares about my well-being. And this was from a survey that Towers Perrin did in 2007. It's since been replicated by Mercer within the last couple of years. And what you can see when you compare business unit outcomes that are reflective of the top quartile of the companies with the top quartile of engagement compared to those with the bottom quartile of engagement, is substantial business value creation. So reductions in absenteeism, reductions in turnover, reductions in shrinkage, which is employee theft, reductions in safety incidents, enhancements in quality, and enhancements in customer satisfaction, productivity, and profitability. So if there is a business case to be made for fostering employee engagement, and that ties back to employers sincerely caring about employee health and well-being, well, here is the essentially the continuum of health, well-being to engagement to business performance. So these are the kinds of measures that may very well be of value and incorporation into business models that more comprehensively quantify value on investment. So we have challenges, and especially from the employer perspective. I've been working with employers for 20 plus years, and it's very hard to disrupt usual business practices. And as I mentioned earlier, organizational expenditures on health are viewed as a benefits or an HR cost. And the notion that health could be construed as a human capital asset is still very difficult for most employers to operationalize. They get it, but it's hard to operationalize this from a business perspective. Part of the reason for that is hurdles with respect to data integration, especially between human resources, where there may be a great deal of reluctance to share employee-specific data because of privacy concerns and HIPAA. Business operations doesn't typically share data with human resources. And the other issue here, as noted, although we have standardized claims detail, and most health plans have, or employers receive pretty much standardized reporting regarding their medical and pharmacy claims and well-being program experience. There isn't the same for employer business performance measures. So for an employer that's looking at this, it can be very difficult for them to say, great, I've got my data. Now, how do I compare this to, or what do I compare this to be able to understand what these numbers mean? And then the last thing, as noted here, results interpretation. Are employers going to take these data seriously? How do we get at issues of causation as opposed to simply association? And when we're dealing with primarily claims data and business performance measures, that may shed some light on where opportunities exist to intervene to create more value or to improve employee engagement or productivity and performance. But what the root cause drivers of those and the specific solutions for those can be difficult to identify. So there's a lot of opportunity for researchers to expand this approach using a good or sound operational model to more explicitly quantify VOI in a way that allows employers to understand the significance of the data and what they can do with it to get at what are the underlying factors that are contributing to the observed results and start to address those as foundational or root cause considerations. So just to summarize, actually, Jeremy, I'll hand this one back to you to summarize.
Thanks, Bruce. And we'll open up to Q&A when we're done. I did answer a comment in the Q&A while you were talking, Bruce, about NICE in the UK, and I always want to call that the National Institute for Cost Effectiveness, but that's not what it is. It's the National Institute on Clinical Effectiveness, I think. So let's wrap up real quick and get to questions. And so I think going back to some of what you were talking about just moments ago, Bruce, about investments in workforce health and well-being, creating business value, I think it's important to know that what we're talking about here is showing a business case for workforce health and well-being, more so than a business case for specific total worker health programs or wellness programs. And it goes back to what Bruce was saying about reducing healthcare costs and also being associated with lower productive waste. While we don't know for sure, as Bruce said, that was an association, not a causal effect. I strongly doubt that just cutting out your health benefits, which would greatly reduce your healthcare costs, is going to be associated with that reduction in waste, right? What we think is happening there is that as you have healthier employees, you have more productive employees. And that extends not just to physical health, but to mental health and mental well-being. And so what we really need is a framework to reflect those dimensions of employee health and the associated business value that can reflect to employers. And while there may always be a need for these idiosyncratic employer by employer, program by program studies, if we're really going to have more of the broad societal impact that I think we're trying to have, we need more standardized employer measurement approaches. We've got to be able to start talking the same language, in a language that everybody appreciates and accepts as being valid. And the measurement of business impact can then drive additional investments in workforce health and well-being. Once we move these concepts of investing employee health out of cost center, out of simply reducing healthcare costs or reducing absenteeism costs, moving it into standard core business operations. A healthy worker is part of your core business operation. is what I think we really need to do. And when we can do that, then we'll create sort of this self-sustaining approach. Well, that may be overstating it. I think we likely will always need to monitor that. As Bruce said, the workplace, the business culture inertia is very hard to overcome, and I think we will need to continue to work on that. But opportunities do exist to enhance this research base and to start moving us in that direction. And these opportunities, these business case research opportunities, are often more than just quantitative, more than traditional economic evaluation approaches. I think what we have to start doing is understanding the value proposition of the various stakeholders at all levels. Understand, why do employees want to be healthy? Why does the frontline supervisor want a healthy employee? Why does the CEO and the C-suite executives, why do they want a healthy workforce? And move all the way through that socio ecological model that we saw in the Harvard model, and think about all of those levels and identify the research needed to speak to all of those levels. And Bruce show clearly some of the challenges, but also some of the opportunities I think that we have to do that. And so I think that is more or less the end of our talk. Bruce, you've got one more slide if you want to advance to it, and we do have a slide with references if anybody's interested in references. But Bruce, you want to speak to this last?
I do. I think Monsieur Babinet is the employer here, and we are the porter, trying to get the employers to shift their focus to what they really need to be looking at, and hopefully we can be successful at doing that. So with that, I will stop sharing and turn it back over to John and Alice.
Wonderful presentation. Thank you. John, can we have everybody on the screen? Does that work? Or just the gallery?
Are you talking about the attendees or the panelists?
Yeah, attendees.
I am.
But if not, it's okay.
I don't think we can.
Okay.
That's what I'm saying.
So let's see, where do we have questions? Looks like.
Yeah. If you want to post, if you have any questions or comments, you can do that in the Q&A or with the chat function, or raise your hand. That would be easy too. It's manageable.
Do you see anything so far?
I am looking right now. Jeremy answered the one question earlier.
Yeah, I do want to, I hope I'm pronouncing this right. Katya Costa Black, I want to thank you for your questions and for mentioning NICE. I think there, we obviously our presentation was very focused on the US and NIOSH, but there's a lot going on around the world on this very same topic, and the World Health Organization is very involved in workplace wellness efforts as well. And so I think thinking about transnational, multinational corporations is maybe another element of that sort of deepens one of those areas of the social ecological model that perhaps we should think about. So thank you, Katya, both for your question and for pointing out the NICE and bringing in more of that international perspective.
I'm seeing a question from Gina Hidalgo. When can it be said that a TWH has been successfully applied? That is a great question. And I think part of the reason for establishing a structured evaluation and measurement approach is to be able to provide the insights that while implementation may not be perfect, at least the trending is heading in the right direction. one of the areas that we're studying now in the context of the TWH model is health equity, and recognizing that participation rates in employer well-being programs and in chronic condition management programs is typically lower among low-wage workers and among people of color. So that's another dimension I think that we can start to think about incorporating into the analysis of success of TWH programs by looking at population subgroups to see how whether all population subgroups are responding similarly and favorably to the TWH associated interventions.
So I have a question. I'll raise my real hand here.
All right.
It seems like every time you turn around, employers talk about how hard it is to hire people these days, or to have, their fully staffed workforce. Can this notion of VOI be used in that regard? And kind of along with that, is there any sort of good housekeeping seal of approval type thing that could be used to, with proper measures to show that a company is really following these principles?
Yes to both. And Bruce, I'll let you jump in as well on this. In terms of employee recruitment and retention, for that matter, there have been some studies that have looked at the role of workplace wellness programs. I'm less familiar with ones that have looked at, say, occupational safety and health on those outcomes. But that's just because I'm less familiar with that side of the total worker health literature. I think that the challenge with that is that is often a transient employer goal. It depends on the workforce we're talking about, and it depends on that broader societal labor market conditions box. When it's hard to get good employees, then employers are very interested in things that will attract and retain the targeted workforce. But when that is not the case, then employers are less interested in that. And so this goes back to the broader idea of trying to have an intrinsic valuing of worker health. And in terms of a good housekeeping seal of approval, I think that's really where NIOSH comes in, and trying to recognize the various programs. But I want to go back to the previous conversation as well about, when can we say, I'm sorry, I'm paraphrasing this incorrectly, but when has total worker health been achieved? And I think we need to say, well, never. Total worker health, individual health is not an end destination. It's a continual process. When you stop investing in your own health, you become unhealthy. And so at the individual level, that means continuing to exercise, to eat well, and things like that. And the same is true for workplaces. When they stop investing in the health of their workforce, that workforce will slowly become less healthy. That doesn't mean it has to be huge formal programs, but it does need to be an ongoing commitment and recognition of the importance of employee health. And we've got another question in the Q&A, but Bruce, did you want to touch on any of that before we get to the question?
I do, Jeremy, thanks. That retention right now, Alice, as you noted, is a big issue for employers, and it is, I think in today's economic climate where, there are limited available individuals to fill particular jobs, employers want to hang on to the employees that they have. What this reminds me of is a nice Harvard Business Review paper from, it was probably 2005 or 6, where they looked researchers looked at comparing Sam's Club and Costco from an employee wage perspective. And at the time, I think Sam's Club was paying $5 an hour. Costco was paying employees $15 an hour. So if you just looked at the salary cost for the two organizations, Costco was clearly spending substantially more money on employee wages. But when one looked at or incorporated turnover, the cost of hiring, the cost of training, the difference was notable and shifted the balance decidedly to Costco from the standpoint of paying employees more actually created greater employee value because of retention, loyalty, and I'm sure other measures that they didn't report. But this is again another illustration of here's an asset. How do you invest in it? This human capital asset. How do you invest in it in a strategic way that yields favorable business results? And I'm sure having high turnover employees doesn't do well for organizational culture. It probably doesn't lend itself to more favorable employee customer interactions, and all of the other factors that you might associate with a high turnover environment.
Thank you.
And Bruce, if you have the Q&A open, this question is right over the plate for you as being affiliated with the North Carolina Business Coalition on Health. So.
Sure. I wish I could say that the Business Coalition on Health is doing this kind of work, but it's a bit of a challenge. This is more the domain of the jumbo corporations. I think the challenge has been employers are generally reluctant to accept a strategy or a tactic unless it's been demonstrated within their own workforce. And too often, the cost of doing these kinds of analyses is decidedly much greater than the cost of the programs that may be being provided. So the one group I would probably suggest contacting is the Business Group on Health, which is the organization that's used to be called the National Business Group on Health, which is in DC and has probably 75 or more of the Fortune 100 companies as members, and probably find more interest in that group from an employer perspective to become involved in this kind of research.
And I'll jump in and suggest that we, sort of as a tangent to this, need to expand our concept of our audiences yet again, as I was reflecting on that question and the idea of, how do we know when total worker health has been achieved, and how do we change the workplace culture and inertia? I think where we need to go are business schools, and where do we train the next generation of CEOs and the next generation of CFOs and COOs, and teach them from the very beginning that worker health is important. And I'm in a business school. I'm in the Bryan School of Business and Economics at UNC Greensboro, and so I have some inroads there. But as I think about it, where we tend to focus that is at the graduate education level, the MBA. And I think we need to work it all the way down to the undergraduate level, and it just be a core business principle from the very beginning that healthy workers are essential to a successful workplace. And so I'm Bruce, or probably more Alice and John. If we can get that into Keenan Flagler, then we're going somewhere, right? So
Yeah.
something for us to think about.
On that inspiring note, we probably need to wrap up. And John, you probably have a few housekeeping things.
Thank you, Alice, and thank you, Drs. Bray and Sherman. Just you will have been noting in the chat, if you would, please take a quick moment and fill out that a post webinar evaluation survey. And as I said, the slides and recording will be up a little bit later on both the Carolina Center and NCOSHA websites. So thank you for attending. And please keep an eye out for our next webinar announcement, which will be coming out shortly.
Thanks for a great presentation, you guys.
Thanks. Thanks, everybody. Bye-bye.